So good afternoon, ladies and gentlemen. I would like to really welcome you to yet another exciting session of the Health Innovations Conference. This session is focusing on global health, specifically One Health, combating outbreaks and mitigating climate change. Before we start, maybe let me turn on my video. It's not able to. So well, before we start, I would like to just lay out a few housekeeping rules. I would like the session to be as interactive as possible, but as much as I want it to be very interactive, we will put all our questions in the chat box. We will have 10 to 15 minutes at the end of all the presentations for questions and answer session. So I'm hoping that our presenters will be able to answer any of the questions that you will have put up. So while I see most of the team here are the GHS team, so we're well acquainted with each other. Any introductions that have to be made can be put in the chat box. Your moderator for today, my name is Judith Nanyondo. I will be the chair for this session. I am the project manager for the CDC IDI Strengthening Partnerships for Preparedness and Response in Uganda project. And I'm extremely happy and honored to chair this session. Our timekeeper for today is Peter Muchibi, who is the monitoring and evaluation manager for the same project that I manage. So you're all welcome. Let's all listen in to these presentations. We have 4 presentations on a range of very exciting topics: legal, surveillance, and laboratory systems. So with that, without wasting any time, allow me to welcome our first presenter for today, who is Miss Martha Isabella Achan, whose presentation is going to be about COVID-19 related statutory instruments. Isabella Martha holds a master's degree in law and a bachelor's degree in law. She's an advocate of the High Court of Uganda and subordinate courts with 12 years of legal practice. She specializes in legal reforms and in other words, Martha supports government ministries, departments, and agencies with expediting the making of repealing laws and amending laws. Her work is closely connected to the Office of the First Parliamentary Council, the Ministry of Justice and Constitutional Affairs, and Martha is currently pursuing a master's degree of science in international public health. Martha, you're very welcome to make your presentation. I will help Martha share screen. A presentation. Kindly give me a few seconds of Martha's presentation. Right. Here you go, Martha.
All right, thank you so much, Judith. Good evening, everyone. I would like to present about the COVID-related laws that we used last year during the peak of the outbreak and this year. Next slide, please. This particular presentation will be divided into 4 parts. The laws that we used to respond to COVID-19, why we needed to use laws, the cases that arose out of these laws, the challenges, success, and lessons learned. Next slide, please. Part of the National Action Plan Health Security Acceleration Team under the GHS. This particular team focuses on implementation of the IHR, and particularly I'm the legal advisor of that team, and my work focuses on incorporating the IHR and the public health laws of Uganda. As we all know, that the COVID-19 outbreak was declared in December 2019, and the first case was confirmed in Wuhan. And in March 2020, it was declared a pandemic. Now, for the case of Uganda, we had the first case on the 21st of March 2020. And by way of background, response to pandemics and epidemics is a responsibility of government according to Article 189 of the Constitution. Next slide, please. Colleagues, on the 17th of March, the government of Uganda passed its first set of COVID rules. Those are the COVID laws under the Public Health Act. Now, these laws were passed before any confirmed case in Uganda. And Uganda was among the first countries in the region in Africa to pass COVID laws. Now, these laws were passed under Section 10 of the Public Health Act, which requires that the Minister of Health should declare a disease, a notifiable disease, for the purpose of the Public Health Act to be applied. Now, COVID-19 is not among the notifiable diseases under the Public Health Act. COVID-19 is not among the diseases that were supposed to report on under the Public Health Act. Therefore, the minister had to actually declare it a notifiable disease under a given law. Next slide, please. So for purposes of this discussion, we are going to discuss particularly on 4 sets of laws. The first set of laws was passed once on the 17th of March. We shall see in figure 1 how these laws were passed. And this is the law which declared COVID-19 a notifiable disease in Uganda. The next set of laws was the law that brought into force testing and isolation at the points of entry. Now, if you're following the current developments in Uganda, this is the law that is being put in place at Entebbe, the testing at the airport. That is the public health prevention of COVID-19 requirements and conditions of entry into Uganda. It is an order under section 36 of the Public Health Act. The third set of laws is the public health control of COVID-19 rules. It's under section 11 and section 27 of the Public Health Act, and it was passed into law on 24th of March. And the last set of rules, the 4th set of rules, can we have, thank you. The 4th set of rules is the public health prohibition of entry into Uganda. These are the set of laws. I'm getting some feedback. I don't know if they can hear me.
Yes, Martha, we can hear you. Francis, could you kindly help us ensure that whoever is not speaking is muted?
So the fourth set of laws was a law to do with the prohibition of entry into Uganda. This is the law that actually closed the borders of Uganda. If you remember, last year we closed the airport, and this year we restricted entry from travelers from India. The next slide, please. Colleagues, other than the COVID-19 laws, we also had to use the Public Finance Management Act, which governs use of funds from the Treasury or the Consolidated Fund. Now, for us to use emergency funds, we had to apply Section 26, subsection 5 and 6 of the Public Health Act. We also had to apply the Uganda People's Defense Forces Act. Now, some of you may be wondering why we have the military being in charge of the emergency, the IMT. The incident commander is an army man. And then also at the airport, we have the military in charge there. It's because of this particular provision of the section of the Uganda People's Defense Forces Act, which provides that when there's actually a disaster that could threaten the security of the country, the military has to take over and control and respond to the control of that particular disaster. In the same way, we also apply the disaster preparedness and management policy. Now, this particular policy also puts in place a structure of who has to respond to a particular disaster. For our case, we actually applied the provisions on pandemics. And that's why we have not just Ministry of Health responding, but every other stakeholders are involved because of this particular policy. The next slide, please. For us to really understand what has really been happening to do with the laws, we need to understand why we're using laws to control COVID-19 outbreak in Uganda. Now, the Public Health Act requires that for the minister to close borders, to put in place wearing of masks, to close schools, to close places of worship, she has to enact instruments under the Public Health Act. That's why you see us referring to COVID-19 rules and COVID-19 orders, okay? So the president announced 35 health measures, but these are just speeches. There's a requirement under our laws, the Public Health Act, for these measures to be transformed into laws, okay? That is why we have these orders and rules in place. Now, initially, the president and the minister were not aware that we actually have to pass laws for the presidential speeches or directives to be implemented in the country. And that is why, if many of you recall, in March 2020, a notice of intention to sue was filed against the Attorney General because the Minister of Health attempted to implement the presidential directives without using rules. In Uganda, presidential speeches are not law. The next slide, please. So you may ask yourself a question, why do we need laws, okay, to control a disease outbreak like COVID-19? One of the reasons is because in the Constitution of Uganda, we have rights to education, rights to religious freedoms, to work, to socialize. Now, for one to be barred from enjoying these rights, you have to pass through a particular law. However, please note that Article 23 of the Constitution provides that one can be denied their personal liberties so as to prevent the spread of a disease. Now, our situation is not unique. Even other countries had to go through the same. We have countries like Kenya, which enforced a curfew through the Public Order Act. We had the country like Botswana, which applied regulations under the Emergency Powers Act. We have a country like South Africa, which also enforced regulations under the Disaster Management Act. The UK passed the Corona Disease Act, and the New Zealand passed the COVID-19 Response Act. Next slide, please. So this was a figure I was talking about. You can see how many rules we have been passing since the beginning of the outbreak last year in March up to date. The next slide, please. So for our discussion and also for understanding, we have passed so far 4 sets of rules which have been amended a number of times. For especially the law to do with the control of COVID-19 has been amended 13 times. The next slide, please. So one of the results of these laws are the cases in court. Currently, we have cases challenging the closure of entertainment centers, contesting the closure of places of worship, the closure of businesses, the restriction of political rallies. Last year, we had some cases there, as well as the non-inclusion of legal services among the essential services. Some we have won them, and others we have been won, like the cases of the contesting the non-inclusion of legal services among health services. We eventually included the lawyers among the essential services. Next slide, please. Challenges. One of the biggest challenges, I won't go through all them because I don't have enough time, is the fact that it was so difficult to explain to the different stakeholders that we need laws to respond to COVID-19 because they had been responding to different diseases like EVD, cholera, without using laws. And it was also very difficult to put a balance between COVID-19 rules and human rights because some of the rules actually impacted on human rights. Next slides, please. Success factors here, we had the political will of the president. As you see, most of these laws were first announced by the president before they actually passed any laws. Then also, as the Ministry of Health, we learned the relevancy of laws, particularly emergency response laws. And then also, the COVID-19 rules exposed the urgent need to amend the Public Health Act. And indeed, this has been expedited as now we are in Parliament. Next slide, please. Lessons learned. We have learned the need to amend public health laws, and I've also realized that many other countries were struggling with archaic laws, outdated laws, and this is because they're not always being applied. So the COVID-19 outbreak actually opened up the eyes of different public health practitioners all over the continent. We also have learned that there's need for more collaboration between different countries, and we're currently coming up with an MOU between the government of Uganda and the Democratic Republic of Congo. Thank you.
Amazing presentation there, Martha. Thank you for educating us. I'm quite aware that many of us did not actually know that there were rules that were governing the control of the measures that were put in place to control the COVID-19 outbreak in Uganda. So could we all give Martha a virtual clap? Virtual clap, kindly go to your your control menu and see how you can give Martha a control clap. So thank you so much, Martha. All our questions will be put in the chat box. Our next presenter, is Dr. Solomon Aquari. Dr. Solomon Aquari is a medical doctor, but also a public health specialist working with the World Health Organization with the Health Emergency Cluster. And she has great experience with outbreak preparedness and response. Dr. Solomon, thank you for honoring our invite for this meeting, this conference, sorry, and allow me to share your presentation.
Judith, if you could just let me share from where I am. I'm hoping that it will help me move faster.
No problem, please proceed.
Thank you. Okay, good afternoon, everyone. It's an honor for me to speak at this conference. My original roots are from IDI, so it holds a very soft spot for me. I'm going to speak very broadly about electronic integrated disease surveillance and response. It's a very big topic and one that we can't complete within even the space of the conference. But I'm hoping that what we will speak about will entice members here at least to start to look into how they can digitize some of the platforms that they already support. Just to give an overview of where we are right now, the picture on the left just highlights the emergencies and outbreaks that are currently ongoing in the African region. If you can look carefully, every country within the region is colored red. Majority of them, of course, it's because of COVID, but there are very many others. If you look carefully, like at South Sudan, at Nigeria, you can see that that's a deeper color, meaning that they've had protracted outbreaks for a very, very long time. And if you also look at our country, Uganda, you can see that we have more than one symbol going on in the country, which means that we have multiple things going on. In 2018, we picked 2018 because that's when the IDSR was revised. There were multiple outbreaks, emergencies across the region, and many of these were identified through two systems that are supported by the WHO within the region, the EBS and the IBS. Now, using the EBS, that is the event-based surveillance, we were able to identify 2,792 reports through media. So this means those stories that you read of on WhatsApp or issues like that, and 142 of those signals actually were potential public health emergencies in 37 countries. Now, just to give an understanding of what IDSR is, it's an old strategy now, started in 1998 by the WHO and member states within the African region, realizing that surveillance systems, outbreak response, public health response systems were really quite weak within the continent, and that a lot of the funding that was coming through was for specific vertical disease programs. So at the time, the thinking was, how do we bring this together and implement a comprehensive public health surveillance and response system for priority diseases, conditions, and events across the whole region and in all African countries. Now, the key goals of IDSR are: 1, integrating those multiple systems; 2, linking surveillance, the lab, and data; and number 3, I think, which should have been number 1, was reduce the fatigue of the district health worker that had to fill all these surveillance forms. And then finally, optimizing the resources that were available. Now, if we think of public health surveillance as the ongoing systematic identification, collection, collation, analysis, and interpretation of disease occurrence, and public health data for timely and robust action, then it brings us to a different way of thinking about electronic IDSR. We also have to think about it along the core functions of surveillance, which are to identify a risk that is present, report on it, analyze and interpret the data available, investigate and confirm that indeed what was reported is indeed going on, prepare to respond, communicate and get feedback, both from the community experiencing the public health emergency, but also from the public that needs to know what's going on. Then monitor and evaluate and supervise. And again, the cycle repeats itself. So thinking about surveillance along those 8 core functions, we begin to see where innovation can truly lend a hand. We also know that public health surveillance is structured, as I mentioned, along 2 channels: the indicator-based surveillance. So that's more the passive surveillance through health facilities. You collect information on HIV, you collect information on malaria, and all this is reported in a systematic way, clear reporting channels with a defined reporting timeline. And then there's event-based surveillance, things that are unpredictable, a flood somewhere, an earthquake somewhere, locusts coming into the country. Those are different events, and they are also reported in a more unstructured way. And therefore, it's very important to find a way to put all of it together to make sure that we don't miss out on any public health emergencies before they become a disaster. So just looking at the EIDSR, it's an application of electronic tools, but you keep the principles of IDSR. So how do we harmonize? How do we standardize? And how do we make sure that we are able to detect early, we are reporting in real time, and we are capable of having a robust response that feeds into the needs at that particular time. It's based again on those IDSR principles. How do you standardize a reporting mechanism? How do we make sure that everyone across the country is reporting in the same manner? Uganda had already done a lot of this with the HMIS, reporting into the DHIS2, using M-Track and those kind of SMS reporting channels. But how do we make sure that even as partners come on board, we are still using that standardized approach? Is it interoperable? Are we making sure that the systems are connected so that, as Judith mentioned, if we are looking at it in a One Health lens, can the Ministry of Agriculture access the Ministry of Health data? And how can we use this for response that is rapid and truly useful? It's not a new way of implementing surveillance. It builds rather on whatever was already there and improves the platforms to facilitate implementation of IDSR. Building on HMIS and ensuring active and timely collection of data on IDSR priority diseases, conditions, and extracted from either patient folders, OPD registers, IPD registers. And if we think about this in the context of event-based surveillance, even just trolling through social media, a report on Twitter, report on Facebook, and things like that, those are all sources of data for the EIDSR. Of course, this feeds into regional committee recommendations within the Afro region for achievement of the IHR 2005, and also goes with the standardization of electronic tools across the region so that there is comparability between the countries and so that we can report on the same indicators. As I mentioned, the key principles establishing this electronic reporting system are: 1, build on what you have already. Do not reinvent a wheel that was already working. Number 2, standardize. Number 3, integrate with the different programs. I think an excellent example of this is the way that reporting on HIV, on malaria, on TB, all feed into the same HMIS, and they all feed into the same reporting forms even, which means that there is less work for the district level health worker to do. Then interoperability, then collaboration is key. If there's no collaboration between the different sectors and the different players, then we'll have a challenge with use of the data. The near real-time approach, data security, again, very important. Our land colleague just communicated about the laws that were enacted in order to to respond to COVID. The issue of protecting individual level data is key, and it's something important that must be used in a reporting system. Again, supporting those core surveillance functions of real-time reporting, alert notification, case-based reporting. I think this is one of the areas that is most benefiting from EIDSR, so that I don't have to fill in a paper-based form each time I have a specific case of EVD, or I have a specific case of cholera, like we have right now in parts of the Southwest, but I can simply pick up a form online and fill it out even on my phone. Also very useful in outbreak management, like contact tracing. I think many of you are familiar with the Go Data app, and it's used in identifying contacts and following them up. Also logistics and supply chain management, information products, and then monitoring and evaluation. There are global initiatives that are looking at innovating disease surveillance. I think one of them I'm hoping you've heard of is the epidemic intelligence from open sources that looks at communities, starts to look at infrastructure where the communities report into, so that's social media, that is TV channels, that's radio, and listens in collecting information, and therefore feeds into an application that can convey all this information into something that's usable for public health action. It's also important that we focus on areas of collaboration, particularly capacity building, technology, and having communities of practice. I'm hoping that each of you will visit the Epidemic Intelligence from Open Sources website. You can find it through the WHO website, and find how you can create, integrate, and engage with other communities using online resources, so that each of us is contributing to this EIDSR. Of course, monitoring is also not easy. We need to check whether people are accepting and willing to use our interventions, whether it's accessible and whether you have availability of data, and finding ways to zero rate some of these websites so that we always have access. And then data quality and completeness, then system flexibility and portability and stability. So just as I conclude, development, deployment, and acceptance of electronic platforms has the potential to change the way that we do surveillance entirely and enable countries to respond to public health threats before they have become public health emergencies of international concern. Thank you very much, and allow me to take this opportunity to encourage all our members to get vaccinated. Thank you very much. Back to you, Judith.
Thank you so much, Dr. Solomon, for such a wonderful presentation. And again, we'll do what we said. We'll have virtual claps for all our presenters. So could we all give Dr. Solomon a virtual clap? Thank you, Solomon. So we put all our questions in the chat box, and we'll move to our next presenter. Peter, please get ready to put up your presentation. Our next presenter is Dr. Peter Babigomira. And he is a pharmacist with a bachelor's of pharmacy from Bara University. He has health diplomacy, health system strengthening, and public health technical expertise. He's attached to the Uganda Ministry of Health Public Health Emergency Operation Centers as the IMT and the Border Health Coordinator. He coordinates the surge team and COVID-19 situation room and the project Border Health efforts. I would like to welcome Peter Babigomira, his presentation is going to be about ZUCAB, which is a tool that has been utilized to strengthen preparedness and response for zoonotic diseases. Peter, you're welcome to make your presentation.
Thank you, Judith. Can you hear me loud and clear?
Yes, you're loud and clear, Peter.
Okay. So thank you and welcome, colleagues. Good morning, good evening, good afternoon, wherever you are. So in It's important to understand how people move across borders, and we call that population connectivity across borders, or which can be acronymed as POPCAB. So when you apply the same method to animals, which we call zoonotic, is where we get the ZooCab. So ZooCab is really finding out the connectivity across borders for animals. And in this presentation, we are going to try to understand what ZooCab is like, what the data looks like, and how we can leverage health innovations to strengthen disease surveillance in animals. So in Uganda, currently many of us know that the borders, Uganda is a country with a highly porous borders, especially as regards animal movements. And we believe that this contributes to the spread of animal-based diseases or zoonotic diseases. Now, we piloted an animal adaptation of the existing human-focused toolkit, which I referred to as the POPCAB, and we use this to collect data on animal movement patterns and interactions, and we use this to inform One Health patterns. This map just shows you how Uganda has very many designated and undesignated points of entry, as well as the roads. So in January 2020, of course, like I said, we had focus group discussions and key informant interviews. We had 2 national level One Health stakeholder meetings in Kampala, and then we had 2 local level abattoir meetings with representatives still in Kampala. So what did we find? We found that the hotspots had changed from what they were previously established in the period of 2017 to 2019. We also found that while in contrast to the local level participants, the national level ones highlighted districts rather than specific locations. And just to point it out, this is consistent with what we have long known about POPCAB, that at the national level, people will generally tell you the regions and the districts rather than the places. And this is why in the methodology, we do both the national level, but also on the ground level. Then we also found that all participants discussed livestock species, but only the national level participants mentioned wildlife. So the local folks, I think because of specialization, only dealt with livestock. Now, participants described seasonality differently, and stakeholders used the results to identify locations for zoonotic disease interventions and sites for future data collections. So the publication, I put the link to the publication in the slide, so you don't need to really strain your eyes so much to see. But what I'm just trying to show you here is that what I'm trying to show you is that in the data, we're able to identify the most recent outbreaks. So previous just means historically, but most recent is close to 2020. And in C, we're able to overlay all the current outbreaks, past, present, and future. So this cumulative increase in the clarity of the data helped us identify common patterns and hotspots. We're also able to find out key locations, animal species, and grazing areas, that's in map A, as well as the major routes mentioned by the different participants. Again, all this is in the publication in a full spread, so you can review. But some key takeaways, we found out that animal movement from Karamoja to Tororo and Malaba was one of the routes, and we found animals grazing in Kabong, Moroton, Nakapiri, Pirit, and Amudat. We also found animals moved from Tororo district to Kenya, formally via Busia and informally via Malaba. We found animals, mostly livestock, come from Kenya to the Chidepo National Park to graze, whereas wild animals will come into contact with this livestock. We found that animals move from Kenya through Busia all the way to Chiruhura for breeding or slaughter. We found that animals move from Uganda to South Sudan through Elegu and Agogi points of entry. We also found animal products, including skins, hides, returned by these routes to Uganda. We found that cattle move from South Sudan through Madiope to Machi cattle market. We also found that animals move formally and informally from South Sudan to Uganda through the porous borders around Oraba. We found animals and people move formally and informally between DRC, Arua, and Madiokolo. During the rainy season, people come to Uganda to farm. During the dry season, all animals come to the Nile River for water. In February, May, and August, which is a festive season, we have children returning to school. We also found that the main selling season starts in Arua. We found livestock and wild animals interacting at Ajai Game Reserve. People in DRC travel from Wanseko Port, which is very busy, in Bulisa district, to Masindi Port, and they take fisheries to Nakasongola. People also transport milk, honey, and fish. Bushenyi to there's a route from Bushenyi to Ruvirizi to Mpondwe to DRC. And bushmeat is transported along formally to DRC through Mpondwe. We found animals also are moved from the cattle corridor to Mbara and finally to Kampala. Animal products move from Uganda to Rwanda through Chanika, and animals move freely in grazing areas that straddle the border. Seasonality patterns. We found, okay, so we have different stakeholders. So as we noted that different stakeholders commented on seasonality differently. So we have Ministry of Agriculture, the Food and Agriculture Organization, then the two abattoirs, that is Wambizi Pig Abattoir and the City Market Abattoir. So starting from the bottom, so at the Wambizi, this is in Narukolongo, if some of you have been there, they found that basically in general, the seasonality patterns are varied, and different stakeholders will tell you different things. So Zuka enables us to understand seasonality patterns, routes, and potential hotspots, and it can be used to strengthen disease surveillance. It can be used to link human and animal wildlife surveillance systems. It can be used to harmonize sample collection and transportation. It can be used to identify areas for possible public interventions, such as quarantine, disinfection, and vaccination. To plan targeted district and community engagements for style, position animal checkpoints and active surveillance sites during certain seasons of the year based on how the data presented. And they're also able to inform risk of zoonotic spread, that is risk-based disease surveillance, and enhance the abattoir surveillance during certain periods of the year. Also, cross-border collaborations in transboundary animal disease control was established, especially between DRC and South Sudan. So, Health Innovations Conference, what do I want you to know? There's a paper, I've put the link in the tab, about new innovations in animal healthcare, but there are different products that are already in the market. Sensors, tags, and collars allow farmers and vets to treat herds at an individual level or at scale. And we have real-time monitoring that is using cameras, drones, microphones, and sensors to produce continuous data demonstrating animals' well-being, productivity, and performance. We have prediction technologies that can harness the wealth of data provided by digital technologies to predict disease or health challenges, and of course, smart building design for animal accommodation, such as the pens and barns. So what does the future look like? This diagram just tries to show you what the future looks like, whereby from farm to stomach or from farm to table, we have digital technologies being used, from sensors to the smartphones and tablets, to big data analytics, to blockchain, and everything is working together. And the reason why you may wonder, we're talking about disease surveillance, Peter, why do you talk about livestock farming? In Uganda, the largest percentage of agriculture is a private good, meaning if you want to make breakthroughs in disease surveillance in animals, you have to make breakthroughs in agriculture and livestock management and the like. So in conclusion, this implementation of an animal adapted population mobility mapping exercise highlights the importance of multi-sector initiatives to promote One Health border health approaches, but also by characterizing animal mobility, we can strengthen surveillance and improve zoonotic disease prevention and control. Health innovations can increase the efficiency and reduce costs associated with these activities. And these are the references that I mentioned. Thank you very much.
Thank you so much, Peter, for such an amazing presentation. Could we have our virtual clap for Peter? Wonderful presentation there of some of the innovations that can potentially help with preparedness and response for these zoonoses. We will have our last presentation from Gerald Aluma. Gerald, please get ready to put up your presentation. So Gerald is the regional coordinator for the global health security within the global health security program for the West Nile region. He's currently pursuing his Masters of Science in International Infectious Diseases Management at Makerere University, following a bachelor's degree in Medical Laboratory Sciences at Mbarara University. He has worked with Makai Health Sciences in the molecular laboratory, spanning areas of research and patient care, and has trained as a field epidemiology frontliner with support from the CDC FATP. He has participated in investigation and response to various disease outbreaks, including Marburg, Ebola, anthrax, Rift Valley, Crimean Congo, and many others. So join me together to welcome Gerald to make his presentation. Gerald, you're welcome. Gerald, please proceed to make your presentation.
Thank you very much, moderator, for all the kind words and for the introduction. And I'm privileged to present to the conference an experience from West Nile about integrated national sample transportation and referral system. Slide is not moving. So as a pilot model or projects of DHS in the region, the West Nile project piloted the model of the integration and found that at baseline, veterinary specimens from communities were transported to the laboratories by individual veterinarians. This generated a lot of concerns of biosafety, biosecurity, and also quality of the specimens. So at that time, there was existence of the National Sample Transportation and Referral System for the human sector. And so this provided an opportunity for us to pilot an integration of veterinary samples under the One Health approach. So the Global Health Security Partner Engagement Project that time piloted the integration, and this was done in West Nile, leveraging on the existing PEPFAR-funded hub system. And currently the hub system is being coordinated by CPHL under the CPHL CDC co-op. So the goal then of the project was to ensure Uganda's continuous and comprehensive preparedness under the One Health approach to avert and respond to public health threats. And so specifically, it was to prevent the spillover of zoonosis or zoonotic diseases from animals to human population while responding to the priority zoonotic diseases that Uganda listed on its list of diseases. So the schematics on the right here indicated the pilot of sample transportation, and this was paying attention particularly to the animal samples from rural part of the greater Arua region, Arua district, that started with the refugee settlements and moved to facilities that nearby, and thereafter to the hubs, which hubs in the region here, particularly is Rhino Campaign Center 4 Lab and the Regional Referral Hospital of Arua Lab, and then the veterinary lab at the Arua district as a regional veterinary lab. And so collectively, when the pilot started, samples were collected at communities, then taken to the nearest health facility, and the hub rider that is routed there picks the samples of both human and animal in different cool boxes and transports them to the hub. which then is packaged for transportation to other labs that are in Kampala, for Entebbe, or in UVRI Arua, or at NADEC, or even CPHL, shown by those arrows. So in the region, along the way, over the years, we collected quite a number of samples for the priority zoonotic diseases, and the map on the left indicates the spots where some of these samples were picked and the diseases that they were investigated. We had anthrax, brucellosis, Rift Valley fever, Ebola, rabies, and yellow fever. And we mapped animal surveillance sites that included communal grazing grounds, game reserves and wildlife sanctuaries, livestock markets and slaughter slabs, porous border points for both human and animal movement that Peter talked about, and also common water points for livestock and humans. So therefore, we had to come up with a schematic that indicated the movement of animal samples integrated in the National Sample Transportation Network. And you could see here in the community aspect, the samples collected by veterinarians from the farm and those collected by human health laboratorians from the communities or homesteads all go together by a hub rider into a facility that is rooted in the system of hub sample transportation. And this hub rider moves with the samples to the hub. Here we depicted the Arua Regional Referral Hospital hub that receives and then sees where the animal samples go. So the animal samples are routed to the Arua Regional Veterinary Lab, which is this one, and the Arua UVRI Plague Lab, which is this one. And thereafter, if there are still samples that cannot be investigated or tested within the region, they are now taken by the CPHL courier or the poster company to the reference laboratories in Kampala at CPHL, and then to NADEC at Entebbe for animal diseases, at UVRI for other human health samples, and at COVAB also at the university for some other animal samples. So therefore, looking at the threats of biosafety, biosecurity, we had to innovate measures to ensure safety and of the security of the samples. And knowing that our samples move in the region with, like indicated in this map, we had to innovate with lockable metallic sample conveyors, which were distributed to all the 8 hubs and stationed under the auspices of Posta Uganda. And these were to improve on the BSBS measures of the samples on transit, but also to make sure that these samples are only accessed by people who hold the key to these conveyors. So these metallic boxes would accommodate about 2 to 3 cool boxes that have ice packs to ensure cold chain system for the samples under that condition on transit. Therefore, we also use the chain of custody forms to document changeover of packages on transit from one driver to another or one courier to another. And it was limited to only 5 changeovers along the way. So we had challenges, especially in monitoring the temperature of the samples of the package on transit, which would only see at the start during packaging and at the reception when we are receiving the samples and unpacking them. So therefore, quite a number of results impressive were gathered along the way. At baseline in 2017, like I said, there were no documented priority zoonotic disease samples that were referred, meaning veterinarians would just move with the samples on their own up to the testing lab. And these were mainly for diseases of economic importance like foot and mouth disease and African swine fever. No specifics to priority zoonotic diseases. But the project from 2018, we had all these up to 2021 overall, we had about 3,701 samples transported by September this year. And the list of priority zoonotic diseases is indicated there. So the successes registered was that we had the successful integration of animal samples into this system. We reduced turnaround time of the animal samples from way over 168 hours to about 36 hours in the first year of the project. And early detection also helped us avert spillover of zoonosis. Out of the 8 outbreaks we've detected here, only 6 have not been spilled over to human cases. And One Health approach was really a major success story that we are able to work with veterinarians and other stakeholders. I beg to submit. Thank you, and over.
Thank you so much, Gerard, for such a wonderful presentation. Again, as per our norms, we will give Gerard a big hand clap. Let's have the virtual claps out there. So we have 5 minutes at the top of 4 minutes at the top of the hour. I don't see any questions in the chat box, but we've had wonderful presentations ranging from the laws that have actually governed the control of the COVID-19 outbreak. We have heard about the journey for the surveillance systems in Uganda. We've heard about ZUCAB as a tool that is used to enhance preparedness for zoonotic diseases. We've heard about the laboratory systems, the sample transportation system, an integrated sample transportation system. A lot of innovation out there that is required to see that, we can be able to have real-time detection and response to these diseases. So since we don't have any questions in the chat box, maybe allow me to just ask our presenter just a few questions to see that we have taken the point home. I will start with our first presenter, our council, our land colleague, that is Martha Chan. So Martha, you've told us about the laws that the statutory instruments that govern the control of the COVID-19 outbreak. And I would want to understand, now that you know that our current Public Health Act is as far back as 1935, what is the progress in amendment of this act? Martha.
Thank you so much, Judith, and thank you so much for that question. Colleagues, as the pandemic was happening, the Ministry of Health had already commenced on the amendment of the Public Health Act. This is a law that was enacted in 1935, pre-colonial era. So we are currently working on the amendment, and we have presented a proposal of the amendment to the President and the Cabinet Ministers. The amendment was approved on the 11th of October. We are currently preparing to go to Parliament to present it to the Committee of Health, and then we shall be ready to present it back to the President for enactment. So the process is underway, and indeed the COVID-19 outbreak has expedited the process, because at some point the Attorney General actually approved the process to expedite the amendment. Thank you very much, Judith.
Wonderful, thank you, Martha. Peter B, you have a question in the chat. Do you have any thoughts on low-cost technology that can be adopted not only for ZUCAB but also POPCAB? As you answer that question, Peter, I also have another question for you. What other innovations can be utilized? What health innovations can be utilized to enhance animal surveillance, preparedness, and response for disease outbreaks? It's really related to that. Peter?
Thank you so much, Judith. And thank you for the question. So I want to give the example of, if some of you are familiar, the system that is being used for human health in regards to COVID. So during the COVID pandemic, we had several issues, example like the issue of the truck drivers. But people were able to link up cameras, barcode systems, and electronic systems such that when someone comes in at the border, you generate for them a form with a QR code, and whichever checkpoint where they meet a policeman, the policeman just has to scan the QR code and they get all the information on the driver, whether his results were positive or negative, whether he's supposed to still be in quarantine. If we could apply a similar system, for example, I mentioned some things earlier, the tags, the RFID chips, if we had a similar system such that when animals come in at the POE, they are chipped or tagged in some way, and a form with a QR code is generated at the border, then anywhere a policeman is doing a checkpoint, they just have to scan the form and they can get all the information. So if we have a suspected disease outbreak, it is much easier to track back and see this particular batch of animals are sick, where have they been, who have they interacted with, and we could use these things. So it's just one example based on what's happening in human health, but being adapted to what's happening in the animal health. Another one is MRI. In agriculture, they have their own electronic system for tracking for disease surveillance. But right now, one of the biggest things that are missing are creating those vital linkages between the APIs or the apps for EIDSR and the other app, such that they talk to each other, such that if a human being falls sick and is captured in EIDSR and animal deaths are reported in the animal app, then someone can easily link the alert back to EIDSR to trigger people to see if there's a relation between this suspicious death with any recent animal outbreaks. I hope I've answered the question.
Wonderful question and response to the questions. In the chat box, we have some questions, and I would request maybe the West Nile team and any other people to be able to respond as we are at the top of the hour. Maybe I would want to ask, have a question for Dr. Solomon. You've given us a wonderful presentation on the journey of surveillance systems in Uganda. EIDSR, like you mentioned, is not something new. EIDSR is not implementing surveillance in any different way. And we know different countries have been able to actually uptake EIDSR, specifically Rwanda. What are those benefits of EIDSR that you think we can pick from other countries as Uganda gets onto the journey of strengthening EIDSR? Solomon.
All right, thank you very much, Judith. Now that you mentioned Rwanda, I think I'll start with the easiest, and I think that's for sample tracking and transportation. Gerald mentioned sending samples through posta, and then eventually it does get to CPHL. But the clear chain of monitoring that sample could be improved. If we found a way to electronically track that system, either with chips or with tags or with barcodes even, so that the sample is scanned at each point that it's transported to the next, I think that's a very clear system where we can obviously improve. Another one that I think is quite extraordinary is something implemented in Sierra Leone, particularly to do with filling out case-based data for case investigation forms. So that you immediately get information on a case, even from the farthest, deepest village, filling out information on a simple app on your phone, and that information is conveyed to the national level immediately. South Africa is utilizing an alert system for their COVID management that automatically calculates number of cases and projections of cases within different areas. And all those different systems feed into the electronic surveillance system. I think those are simple things that we can pick, but we should also be encouraged with our own progress in EIDSR, particularly in use of the QR codes on our COVID-19 tests. I think even that needs to be applauded. Slow progress in getting through to a point when we don't actually have to print those results, and we have an interoperable system within the region, also limiting the number of times someone has to do a COVID test as they travel within the East African region. But I think that these are things that we can move towards. Thank you very much, Judith.
Amazing. Thank you, Solomon. So my one last question, I know we are 4 minutes to the to the past the top of the hour, but I wouldn't want Gerard to leave without answering this question, and it's related to what Justine has put in the chat. We've had very wonderful progress on this One Health integrated sample transportation system in the West Nile region. What are those lessons that we have learned from that that you think can be passed on to other regions? Have you heard of any progress of transferring the same approach to other regions? Have you heard of anything that is ongoing in other regions that would also be beneficial to us? So Gerard, I want to give you a few seconds to respond to that question.
Thank you so much, moderator. As quick as it is, yes, the samples still, animal samples still move through the same system, the National Sample Transportation Network. And the indication there was that up to 30th of this month, the data indicated that we still transport samples through there. And you could see the many cases of rabies that we've had in the region. All our samples have moved through that same system. And also the scale-up plan to take it to other regions of the country is highly recommended. But the best example was seen when we were partnering with other partners in Kasese region, where we were able to also see a few animal samples going into the hub system. I think if stakeholders take this up as One Health platform, we can take it to other regions of this country. In as far as the success story or the major lesson learned is concerned, I think we have been privileged to scale up the collaboration channels with the veterinarians and other One Health stakeholders in the region, to the extent that our task forces, whether it's the COVID task force or a DTF meeting or district rapid response team, the veterinarians and people from the environment are incorporated in these structures and platforms. So that has been one of our hidden success stories and lessons learned, that everywhere we go in other regions, districts can actually work as a One Health approach to public health emergencies. Thank you, and over.
Wonderful. Thank you so much, Gerard. So thank you all, ladies and gentlemen, for joining in for this session. Before we end, we want to have a group photo. So I kindly request all of you to turn on your camera so that we can have a photo. As you do that, I want to thank you so much for joining in. I want to thank all our presenters for taking the time to the session, and also to be able to educate us, especially Martha, who was educated us. Thank you so much. And as we end our meeting, please turn on your cameras. And as soon as the photo is taken, our meeting will be adjourned. Let's turn on our cameras, please. Right, so I think our cameras are all on. Francis, or the academy team, Flavia, have you been able to snap all of us? Okay, let's smile. All right. All right, thank you all for joining in. I want to wish you a good afternoon, a good evening, and bye-bye.
Just a minute, just a minute. Okay, just one more shot. A big smile. Yay. Thank you all.
Thank you so much. Thank you, the Academy, for hosting us. Bye-bye.
Thank you all.